Good evening, everyone. I'd like to welcome you to tonight's webinar, Mastering Bone Grafting and Regeneration for Predictable Outcomes. We're excited to have you join us for what we promise will be a valuable and insightful webinar. It's my pleasure to introduce our speaker, Dr. Robert J. Miller. Dr. Miller earned his BA from NYU and an MA in biology from Hofstra University. He graduated with honors from NYU College of Dentistry, where he received the International College of Dentists Award for Clinical Excellence and completed his residency at Flushing Medical Center. He is a board-certified diplomate of the American Board of Oral Implantology, an honored fellow of the American Academy of Implant Dentistry, and currently chairs the Department of Oral Implantology at the Atlantic Coast Dental Research Clinic. Dr. Miller also directs the Center for Advanced Aesthetic and Implant Dentistry in Delray Beach, Florida. We are honored to have him with us tonight to share his expertise on bone grafting and regenerative techniques. And with that, Dr. Miller, the floor is yours.
Thank you, Leslie. Let me make sure I get this to share here. Does that look good now on the screen?
It looks great,
Yes.
Dr. Miller.
Okay, let's get started. We have an hour to spend with each other tonight, and I hope that by the end of that hour, I have changed your perspective on the world of bone grafting. Now, this is not a definitive course. If you want to take a definitive course, you come to one of our hands-on workshops. This is more or less of a primer. It's an entree. It's something that changes your perception, changes the way you look at not just how you graft, but what you graft with, the biomaterials that you use. And let me make sure this clicks on now. No, there we go. I do receive an honorarium from Implant for doing this, but I have no other conflict of interest with regard to this. So when we talk about understanding the key biologic factors in bone regeneration, there are several. And we know that either prior to or simultaneous with implant placement, it's the area in oral implantology that's the highest complication rate or highest failure rate. And the failures of grafting may give you an impression that they're kind of the same, they have a common pathway, when in fact, what I call the mode of failure can be very, very different. It can be related to the type of graft that it's used, the type of membrane, if you use one, poor surgical execution, or a deficiency in the soft tissue complex we call the dentogingival complex. And then you must understand the local factors part of grafting. And then after you understand the local factors, what it is that you're trying to achieve, you have to select the appropriate materials. And then you have to have the proper sequencing of procedure. All of this is important. Your outcome is only as good as your weakest link. So we're going to compare and contrast various key biomaterials. We'll discuss what the dentogingival complex is, how it reacts to biomaterials, and most importantly for me, the compression of the wound response, meaning we treat these cases in less time, but at the same time, getting a better quality of bone as our outcome. So where are we in grafting today? Well, if you go to any one of the dental conferences, there's a vast array of biomaterials. In fact, if you go to a dozen different implant companies or bone graft companies, you'll get 20 or 30 or 40 different biomaterials that you can use. And how do you decide which one is going to be best? Because if they all reacted the same, really wouldn't make any difference, would it? You just tell your staff, I need some biomaterials, get the best deal. So, buy 10, get 4 free kind of thing. So unfortunately, if you do it that way, if you buy in biomaterials that way, you're gonna end up with more complications than you were ready for. And we have varying degrees of success. Now, I love starting with this because this comes from social media. This is obviously the post-op of a bone graft that was placed. Now, if I told you that this was 2 to 3 months post-placement, you would say, all right, not a big deal, because you can still see graft particles extravasating from the graft complex, and it's still young, and in time this will turn over. But if I told you it wasn't 3 months, but 3 years post-graft placement, you would say, That's suspect. In fact, it looks like this material may never turn over. So perhaps the choice of biomaterials was incorrect. Perhaps it was the way it was prepared. Perhaps it was the way it was placed. Perhaps it was placed in a site that wasn't bleeding. It didn't have good vascularity, and the body walled it off instead of replacing it. And then if I said to you, would you feel comfortable placing an implant in bone that looks like this? You'd probably grin and with a sly look and say, well, I'm not so sure I'd like to. And if we look at this list basically represents all of the available graft materials in the world. And I will say this. There's no such thing as a bad graft material. There's bad ways of using it. There's bad ways of hydrating it. There's bad ways of delivering it. There's bad places that you can put it into. And if you use the material incorrectly for the intended use, you'll get a bad result. It's not related to the material, it's related to the way it's used. And I'm not going to go through point by point here to give you the pros and cons of each one, but it's incumbent upon you to understand that not only are there differences, there are profound differences. For example, if we were to compare the biology of the turnover of an autograft, autogenous bone, as compared to the turnover of a xenograft, night and day. And if I'm going to place an implant in a site, I'd prefer to use autogenous bone in that site, knowing that I'm going to get a very high percentage of vital bone. If I plan to place an implant, I will not use a xenograft because it will not turn over, just like the radiograph I just showed you. It doesn't mean that xenograft is a bad material. In fact, I use it all the time. I would use it if I'm doing an all-on X. I'm extracting 8 or 10 teeth, but I'm only placing 6 implants. What do you do in the sites where you're not going to place your implant? Well, I'm going to place a non-resorbable graft material. Why? Because if that's going to be the pontic of a restoration of, say, an FP1 prosthesis, or it's going to be under the intaglio surface of a hybrid restoration, I don't want that ridge to resorb and shrink, creating a space that will then result in food impaction and then result in peri-implantitis. So, as I said, there's no bad graft materials, bad ways to use it. But if you use it correctly, xenograft will be stellar. If you use autograft correctly, it will be stellar. If you use allograft or alloplast, it will be stellar as long as you use it correctly. This is what happens when you use it incorrectly. This was a xenograft implant placement and graft on the facial. And instead of turning over into bone, it became fibrous encapsulated. Not only did it become fibrous encapsulated, it became inflamed. There was a chronic inflammation around the material. The body was trying to clear it, and then it elicited a foreign body reaction rather than producing bone. And that's a terrible outcome because this implant now has failed. So what should we accept as the clinical efficacy of these procedures? And after choosing graft material, what's the best way to prepare it and then to deliver it? At the same time, you've had to balance the ease of handling, the ease of placement, the cost effectiveness, and last but certainly not least, you want to enhance the clinical outcome. You want to get the best potential clinical outcome, which in this case is the highest percentage of vital bone with the correct volume that you need. So we look at certain parameters, resorbable versus non-resorbable, dense crystalline versus low crystalline or non-crystalline. Resorption time, what's the resorption time is going to be? And if I ask the average clinician who uses an allograft, how long do you wait before you place an implant once you grafted that site? And the average answer is about 4 months. Sometimes people say 3, sometimes we'll say 5 or 6 months. On average is about 4 months. Why 4 months? What has to happen first? First, that biomaterial has to resorb. We call that the catabolic remodeling phase of bone. The body's going to go in, it's going to enter, it's going to create a new vascular bed, it's going to bring in cells that are going to help to resorb and eliminate that biomaterial. And then only after that occurs can we get anabolic bone growth, where it's replaced by autogenous bone. The degree to which that bone is replaced by autologous bone is going to be dependent on its crystallinity, its particle size, its resorption time, and the means by which it's resorbed away, solution mediated versus cell mediated resorption. The wrong choice will give you a bad outcome. So if we look at the quality of bone at the time of implant placement, the percentage of vital bone at the time of implant placement, percentage of vital bone after integration as it continues to turn over in function. We look at this now, and this is the type of case that I did for decades. I'd extract the tooth non-destructively, don't harm the soft tissue, keep the septum of bone, don't fracture anything, and then you bring the particulate, and it's just time consuming. Sometimes you get little voids. Sometimes the bone graft falls off your spatula as you're delivering it, then you pick it up off the tongue and deliver it anyway, and how it's contaminated. And then, of course, once you've placed that particular graft material, now you've got to protect it. You've got to cover it. So you've got to cover it with a collagen membrane or a PTFE membrane. And then after you will cut it to slightly larger than the defect size. You will tuck the margins underneath the flap, and then you'll do a nice suture technique. Normally a horizontal mattress suture to hold that membrane from moving. I'm going to just skip ahead here a little bit to show you what that looks like. So it's tucked underneath the margins. A suture using a horizontal mattress suture, in this case with railroad ties. I'll skip ahead here, showing you how we do this and holding it in place, then covering it with a little bit of gel. But I don't want you as a clinician to have to worry about the upper part of this. Leave that to the researchers. Leave that to people like me who are in the research world as well as in the clinical world, because we spend a lot of time designing bone grafts to do all the things that we needed to do in the proper time frame. But I want you to look at the bottom three: the quality of bone at the time of implant placement, important if you want to get good initial stability; the percentage of vital bone at the time of implant placement, uh, important with regard to the degree to which it's going to integrate, and then the percentage of vital bone after integration in function, which should increase over time. It can only increase if that bone graft material has resorbed away. So alloplast, the synthetic bone, and xenografts, or high crystalline DHAs, look the same macroscopically. They have the same handling characteristics. And when I say to someone, most often, why do you use a xenograft? And they look at me and they smell like, wow, it looks great on a radiograph, especially if I've been doing a sinus graft. It looks well compartmentalized if you do it correctly. Fine, I accept that. But then it begs the question, what about the rate of resorption? Is it osteoconductive versus osteoinductive? What is the percentage of vital bone, which is mineral density, and the rate of complications and failures? If you can't answer the other 5 questions, that makes your choice of material suspect. And you need to start questioning why I'm using that in place of other better materials. And if we look at something like this is the coronal section of a sinus, this being the palatal vault, this being the outer facial bone, this being the zygoma, and this being the residual ridge. And then we look at this where an implant is placed with a xenograft in place. Here's host bone, real bone. Here's biomaterial, what we call hydroxycrapotite. And over a period of time, doesn't take long, these implants deintegrate. Here are bone graft particles, xenograft particles, held together not by bone, but by connective tissue. It never turned over into bone. I could show you case after case exactly like this. Wrong choice of biomaterial for that case. I'll show you an even more profound case. This case was done by a periodontist here in Florida, and after 3 years, he had said to the patient, "I'm sorry, this didn't heal properly. I can't place implants here." Patient ended up in my practice. I did bilateral sinus revisions, removing both sides. I'm going to show you the upper left sinus. I'm going to show you what it looks like when we go to remove this. So I'm going to do the classic oval window. Remove the window. And inside that sinus is the graft milieu. This is not bone. These are xenograft particles held together by connective tissue. And you can literally peel this graft complex out of the sinus. How do you expect implants to survive in a mass, amorphous mass of graft material that has no cellularity and no vascularity? You can literally peel this away. Okay? This is nothing but a foreign body. Remove it in its entirety, re-raise the membrane, put a good resorbable graft inside there, and then we can go ahead and place our implants. It was none other than Stuart Frome, Dennis Tarnow's right-hand man at New York University before Dennis left for Columbia, who wrote a paper with Stephen Wallace, a periodontist uh, from, from Connecticut. And the title of that was The Survival of Implants in Bioos Grafted Sinuses. And for not for years, but for decades, Stephen traveled the world lecturing on that paper. He made an industry out of a single paper. And yet, when Stewart left New York University and then went and wrote a chapter for Ole Jensen's The Sinus Bone Graft, Ole Jensen being a world-class oral and maxillofacial surgeon from Denver, Colorado, he went back to some of these patients and said, all right, we're going to do the histomorphometry. Now that everything is healed, we're going to go back in and take bone cores. Let's see what's really here. And what they found, what's in chapter 17 of the sinus bone graft, he found only 25% vital bone, 25% residual xenograft that still hadn't turned over after many years, but 50% connective tissue, not bone. If it was 50% bone, it would be different. It's only 25% vital bone, 50% connective tissue. How do you expect implants to survive in 50% of connective tissue? The answer is it does not. It fails eventually. And it fails because of this. The body views these particles not only as a foreign body, it gangs up against them. It forms something called a multinucleated giant cell. And these collection of osteoclasts in this massive army envelop these particles and cleave off pieces of them and shunt them to the lymph nodes, the lungs, and the spleen. And it can actually suppress immune response if you use enough of this material. But the problem with this is not just the fact that it transports it away and does not resorb it. The problem is when you have a multinucleated giant cell foreign body reaction, it produces connective tissue, not bone. And that's why histomorphometrically, when the big guys who wrote the original papers went back in and said, you know what? It may not be as good as we thought it was. This is the reason why, and this is the reason why I will not use a xenograft in a sinus. Again, I'm not anti-xenograft. I use it, and I use it very successfully, but in the ways that I delineated earlier. So xenograft is not resorbable. It's a filler only, no release of free ionic calcium, low percentage of vital bone, lower stress-bearing modulus. You will experience a foreign body reaction. You will get lymph node accumulation, and you get repair as opposed to regeneration. Repair means it fills in a space, so there's no longer a space, but it doesn't regenerate anything. It just fills in the space. So the clinical outcome of bone grafting should be the regeneration of vital host bone. So why use a highly resorbable graft? Number one. Number two, what are the biologic effects of the resorption of calcium phosphate materials? And three, during the resorptive phase, is there a contribution of the release of free ionic calcium? Now that's extraordinarily powerful. Why? Let's think about how the body resorbs its own bone. Because our skeleton is constantly being regenerated. It's constantly being resorbed away and then replaced. The cell that does that is called the osteoclast. The osteoclast comes along through solution-mediated resorption, secretes an acid. It dissolves the bone in front of it. That bone then releases three things. One, it releases bone morphogenic protein that's trapped within the bone complex. Two, it releases calcium ions in the breakdown of hydroxyapatite, HA, and releases collagen that's stored in between the crystals of HA. That then stimulates the cell right behind it, which is the osteoblast, to start growing bone. So if we have a material that does not release calcium because it can't be resorbed, has no collagen internally, has no BMP internally, how do you expect bone to form? You could be using autogenous bone. You could take bone cores, using a trephine, crush up the bone. You get excellent bone. But you have a secondary surgical site. You have morbidity attached to it. Are there other materials that we can use that imitate the action of autogenous bone? And the answer to that clearly is yes. Let's look for a moment at BMPs, growth factors. This represents a, uh, a cell membrane. This represents the cell nucleus, this space in between that we know as the endoplasmic reticulum. So what happens is BMP 2, 3, 4, and 7 reach the BMP receptor. That receptor releases chemicals. The chemicals go into the endoplasmic reticulum. They reach the nucleus and they upregulate nucleus metabolism, in particular mitochondrial metabolism. And when you upregulate mitochondrial metabolism, the mitochondria are the building blocks. They help manufacture the building blocks of every single tissue, enzyme, chemical component, hormone in our body. If you potentiate that, if you upregulate it, you get more tissue, you regenerate more tissue more quickly. So, what is the material that acts just like BMP? It's almost as powerful as BMP? Right here. Free ionic calcium. This is called the calmodulin receptor. And when that free ionic calcium reaches this, the same chemical messengers occur that then get into the mitochondria and upregulate cellular metabolism. So if we're using a material that's releasing calcium, we've got one leg of our three-legged stool. That's important. Now let's look at this graph. This comes from the orthopedic literature. And this is a study of 4 different types of cells. Human osteoblast, the MG63, which is a human osteosarcoma line that we use that mimics the action of osteoblast in the laboratory. Then mouse and rat osteoblast. The white column represents how many osteoblasts are present when no calcium is present. Very, very low. The black one represents how many osteoblasts are present when the right amount of calcium is present. You can up-regulate the number of bone-producing cells, osteoblasts, if you have the release of calcium within your regenerative site. In fact, in here it shows up to 500% increase in the numbers of osteoblasts. Let's look at it a different way. How quickly can we expect those osteoblasts to become active and start producing the building blocks of bone? So we tested, in this case, 2 different solutions. A 1 millimole solution of calcium, a 5 millimole solution of calcium, and tested the mitochondria at 5 minutes, 10 minutes, 60 minutes, 2, 6, 24, and 48 hours. And we looked for the production of early proteins, which are we call MAP kinases, mitogen activated protein kinases. We can label them with radioactive thymidine and actually measure how much of those early proteins are being produced. How powerful is this? Not only can we increase the number of osteoblasts 500%, we can now increase the metabolism of those osteoblasts by 4 to 500% within only 5 minutes. Now that is what I call powerful. If you want a strategy to compress treatment time, to compress the wound response, to get faster turnover of graft material, to get faster integration of your implants, use a good calcium releasing material. Now, do you want to see what that looks like clinically? You don't believe that what I'm saying as far as the clinical significance of that? This is one of the few papers you'll ever see. This was printed in the European Academy of Osseointegration by a friend of mine, Adriano Piatelli, who's the editor-in-chief of the EAO journal. And what they did was they placed 10 implants in the upper arches of these Italian patients with the proviso that 2 of those implants were going to be explanted at 2 months. They were identical implants. The only difference was one was just acid etched, one was acid etched plus had a calcium releasing material embedded within the titanium oxide surface. This is what the acid etched implant looks like at 2 months. Average implant, bone to implant contact. A little bit of crestal bone loss and remodeling. No real turnover, no real activity of bone. Now let's look at the same patient with the addition of a calcium releasing surface. Look at the percentage of bone. Look at the rapid turnover of the bone in direct apposition to the implant surface. And look at the density and the maturity of that bone in 2 months. Look at them side by side. Same patient. This is osteoconductive. This, with a calcium releasing material, is actually osteoinductive. So what is the ideal calcium releasing biomaterial for grafting procedures? Well, for me, it's OsteoGen. It's a non-ceramic material that is highly resorbable, hydrophilic, replaced by autogenous bone at a rapid rate. It does release free ionic calcium, making it osteoinductive. You get a high percentage of vital bone, higher stress-bearing modulus, no foreign body reaction, no lymph node accumulation, but for me, most importantly, you get regeneration, not repair. You actually get replacement of the graft with vital host bone. Now, can we combine these graft materials with current concepts? I love making composite grafts, which means that if you're going to have your best results in a grafting procedure, use growth factors. In fact, the best growth factors that we can get they're available essentially for free, come from the patient's blood. That's what PRF is. It used to be PRP, now it's PRF. So we have fibrin-based materials. It has a collagen substrate. It has embedded graft material. And then we can carry that and hydrate that. And then it acts just like a collagen membrane. Here's an example of the different forms that I can take. The original ones were bone plugs right here. And there are several bone plugs like this on the market. It comes in a slim, a large, extra large. It now comes in bone matrix, small bone matrix, large bone matrix. It comes in bone blocks with a higher percentage of bone. You can get pure OsteoGen that doesn't resorb. You can get granular OsteoGen that resorbs completely, but there's no collagen. Many, many different forms. So it maintains the volume while the graft resorbs. It contributes both graft and collagen to bone growth. It's porous, it's hydrophilic, takes up blood components beautifully, and can be used as a carrier for almost anything. Now, let's talk a little bit about hydration, because if you're using bone grafts, obviously you're going to be hydrating it with with something. And if you use the wrong material, you'll end up with a not so stellar result. And the first one is sometimes clinicians will use a few drops of sterile anesthetic solution to help carry the material to where they want to go. But here's the problem. If I ask you what the full name of lidocaine is, you would say, oh, it's lidocaine hydrochloride, which makes it a what? It makes it an acid. And an acid, if you look at the physiologic pH of tissue, the physiologic pH of tissue is 7.4. If you drop that pH slightly, even just 7.1, you completely shut down what we call the EGR1 gene in the osteoblast, which stands for early response gene 1. It's like a light switch. You turn that switch off, no collagen is produced, no bone is produced. And that's why when you put a biomaterial in a site and you get the catabolic remodeling phase, you can't get bone growth while the pH drops. While the osteoclasts are doing their job, the pH is acidic because the body needs to resorb away all of that hydroxyapatite. Then, when that's done and the pH starts to return to normal back to 7.4, that's when the osteoblast flip the switch back on, and that's when you start to get bone growth. So you say, all right, I'm not going to use anesthetic solution. Thank you. But what are you going to do in its place? You're going to use sterile saline. Now, sterile saline is okay. It's a neutral pH. There's no bioactivators, no cells, no growth factors. Plus, when you fill up a porous granule with saline, the surface tension in that granule prevents venous blood from going inside and actually delays vasculogenesis. Then you say, all right, I'm not going to use sterile saline. I'm just going to use blood from the site. As it bleeds, it'll bleed into my bone graft. That's actually a good choice with one caveat, and that is whole blood, which contains a lot of red blood cells. As those red blood cells break down, they become acidic and they become cytotoxic. And that stimulates a cell called the M1 macrophage. And that macrophage that turns into an M1 macrophage helps to break down tissue. It helps to create collagenase, elastase, gelatinase, matrix metalloproteinases, things that break down tissue to rebuild it. You don't want a process of breakdown, a very, very profound breakdown before you regrow bone. I'd rather go directly to bone growth if I can. Rapid removal of the graft material and rapid anabolic bone growth. How can we stimulate that? Well, if you're a PRF user, the fluid, the serum that collects in the bottom of your collection tray, which we call autologous serum, is a much better choice because it's a pH of 7.4, doesn't become acidic, but it's low in growth factors, low in cellularity, it is angiogenic and is antibacterial. Fine. And if that's what you want to use, that's great. And this is what this looks like. In the bottom of the collection box, after you squeezed out all your fibrin plugs, that fluid that collects in the bottom is autologous serum. That contains tissue adhesion proteins, thrombospondin, vitronectin, fibronectin, albumin. It makes it sticky, not sticky bone, but it becomes sticky, so it becomes better handling. If I pick it up with a spatula, it doesn't fall off my spatula. It sticks to my spatula as I turn it upside down. But that's not sticky bone. It just holds the granules together, makes it better handling. The last one is autologous plasma. Autologous plasma is the best. It's the most effective, again, just like serum, pH is 7.4. And you have the highest percentage of growth factors. High cellularity, it's angiogenic, antibacterial, analgesic, anti-inflammatory, and it stimulates M2 macrophage polarization. The M2 macrophage is directly involved in tissue regeneration in the anabolic bone growth phase. So if I'm going to place a bone graft and I'm going to hydrate it with something, I want to hydrate it with something that's going to potentiate the pathway that I'd like it to take, which means that it goes directly to anabolic bone growth. So I always stay to the right of this hydration paradigm. That's what it looks like. You spin down a plastic tube for 3 minutes. You take a syringe and you just draw off that yellow fluid. And you simply take that, let's skip ahead here. You mix it with a bone graft material and you'll see the bright red, that bright red, those are the platelets, not dark red. And then you mix it and then you carry it, you make sticky bone out of it. And this is what it looks like when you use one of these OsteoGen plugs with serum alone. It has no pink to it, it has no live cells, it has no platelets, as opposed to the right that's hydrated with plasma. So the one on the right is far more biologically active. It contains a calcium-releasing bone graft material, OsteoGen. It contains type 1 bovine Achilles tendon collagen, the same identical collagen that's produced by the osteoblast, and is hydrated with living cells, platelets for long-term release of growth factors, and leukocytes, white blood cells, that are the main reservoir of vascular endothelial growth factor, which rapidly forms a new vascular bed. So your bone graft material will now turn over more quickly, and we go directly to anabolic bone growth. So I'm actually entering my surgical sites in practically half the time that I did when I was using allograft material as my graft material. So I'm going to go through this quickly, because I've discussed this already. Here's some examples of different kinds of plug materials. Collarbone RTM plug from I think it's by Horizons, sponge Zen Graft, which is a plug, but instead of OsteoGen, it contains a xenograft. And then, of course, OsteoGen that has the OsteoGen particulate inside. And this is the whole concept of this. You want the bone graft to be held together in that collagen matrix so that it cannot migrate. It will not move from the site where it's placed. And because now we hydrate it with PRF, it has a built-in PRF membrane, which makes it cell occlusive. So when you're using it, it doesn't get contaminated with saliva. Soft tissue cells don't grow down inside it. So what I did was, when I started using this material decades ago, I said, all right, let's do this. The best way that I know to determine the efficacy of a bone graft material is to do a split mouth study. So let's do this. I'm a big PRF user. I've been using it for 25 years. Let's do one side of the mouth with only PRF membranes and look at it at 2 months. Then let's look at the contralateral side and say it's going to be one of these bone plugs, but hydrated with PRF. So it's got the additional bone graft material and collagen. And this is what it looks like. Same amount of time. You still see a lot of lack of density here, even though it's healing, and it will heal eventually and heal very nicely. Look at the density of this material. And this is not graft material. It's long resorbed away. Look at the density of the bone that has already formed there in that same period of time. That's amazing to me. So I'm compressing the treatment time in about half. And then you can look at all of this great research from Periodontology 2000, where they've done every kind of combination, demineralized bovine bone matrix plus collagen membrane, uh, porcine grafts with collagen membrane, demineralized freeze-dried bone with collagen, freeze-dried bone with collagen, combination of freeze-dried bone and demineralized freeze-dried bone, plus a polytetrafluoroethylene membrane, freeze-dried bone with PTFE, freeze-dried bone with collagen, and then nothing, just unassisted, and just let it heal by itself. It's amazing. Look at all these dots all over the place in terms of the quality of healing that we get. This being the cost as it goes up, and this being the width loss, depending on the grafts that we use. Look where unassisted healing is. Unassisted healing, no cost, but at the same time, the most height loss. So now we look way up here, and you say, all right, this is the demineralized, the bovine bone matrix with a collagen membrane, the highest cost, but the least amount of height loss. So I look at this and say, well, I don't want this. I don't want the very worst part. I don't want this part either because that material is never going to resorb. I want something down inside here that's going to be relatively low cost and at the same time have relatively little bone height loss. And that's actually where these bone graft materials fit in. And then we can look at the literature and go, uh, same mouth studies, split mouth studies with the bone graft material, without the bone graft material. Look at the difference in height loss. And we can also look at the uh, osteoblast proliferation on these things as compared to uh, BioOS collagen, human bone allograft, and OsteoGen plug. So we look at this and say, which is the most biologically active? Well, this is the one. This is the one with the OsteoGen material in it. So it's quite profound when you see this. And if you look at the summaries, you look at the way they work, look at the way they get hydrated. Here's a beautiful bone matrix study where I was now taking plasma. You see the bright red? That bright red are all the platelets. And as I hydrate this, you can see how much of this material is adsorbed into the bone matrix. And you can keep doing this. You can see the osteogen particulate. You keep doing this till you super saturate it. How do you know when it's super saturated? Well, it starts to flow out the edges. But look how much of this fluid it's taking up. Now it's starting to be super saturated. You're seeing it start to come out of the membrane itself. And I stop there. Letting it harden, look at the graft now. And we pick it up, and that's a built-in PRF membrane in a bone graft that will not migrate, that will maintain its shape. You can put bone screws through this. It's amazing material. So within a defect, outside of a defect, with bone screws, I like to use this. So we can look at a case like this and say, uh, what's our protocol for removal of a tooth? Remove it, debride out all the pathology, apical cyst, peroneal ligament. We deepithelialize the sulcus, and then we decorticate. These are critical size defects within that cortical zone. Then we take a bone plug, and as we press it in, look how quickly blood components adsorb up into the plug. We place it down to a point where it's below the tissue level, not necessarily to the bone level. We can have it above the bone level, make the bone grow up. But we want it to be below the tissue level because those cells need to go across and repopulate this. If you have it at the same level, it blocks the fibroblasts from migrating across. And then we do a nice horizontal mattress suture over the top of this to hold it in place. Here's a video of not the same case, but the same type of case, same tooth position. So I'm going to go ahead and start removing the pathology. First one we use, of course, is a curette. Trying to get as much as the gross pathology. Look at the size of that apical defect. Then we're going to clean up the peroneal ligament, any remnants of that, clean up the uh, seated sulcus. Look at this, and you see me peeling away, literally peeling away the peroneal ligament from this, and then going apically, making sure there's no pathology left here. And I don't care what you use. I love lasers. You can use piezo surgery, and you can use round burrs. You can use drills to do that, but make sure you do this. Now I'm going to go ahead and decorticate this. Again, I just happen to have piezo surgery units, so I'm going to take the piezo surgery unit and make my critical size defects in there to create bleeding points. You must have bleeding points. You must go through that dense lamina dura because that's where your vasculogenesis is going to come from. Now we're going to go ahead and just irrigate this a little bit. I'm going to irrigate this with a little bit of autologous materials. And there's the blood coming up from the bottom. And now I'm going to take my plug. I'm going to place it down inside here. And you can see how quickly that fluid gets taken up. And then we take a large bone plugger, the largest diameter that we can use that fits into the defect, and compress this down into the defect. Remember, we want it below the tissue level. We can have it above the bone, but it needs to be below the tissue level. And you can't overcompress this. Don't worry about it because it's collagen. All right, so that's the perfect position we want this. That's a suture that goes over the top. Here's another one, different patient, same tooth position. We go ahead, place our plug. We do a horizontal mattress suture over the top. That's all we need. We don't need anything else. And then we're going to come back in 1 week. I'm going to show you the 1 week post-op on this case. That's the 1 week. Look at the quality of the tissue in 1 week. Look at the thickness of the tissue. Look at the lack of redness where the sutures go through the tissue. In another day or so, it'll be completely closed up over the top of this. But look at the thickness of that keratinized stone. That's amazing to me. But look at the radiographic interpretation. It's the opposite of placing a particular bone graft. When you place a particular bone graft, um, and the classic case is going to be xenograft. You put it in and you see this big white amorphous mass. This is the opposite. This appears mostly radiolucent to me because as it heals, this is what happens. See that density? See that trabeculation forming? That is my feedback, radiographic feedback, that this site is now ready for implant placement. And that's why it's so important to me that we do that. I'm going to skip over a little bit of this right now in time. You're moving the molars, and it's a 3-rooted molar. You can take one of these plugs and literally cut it into pieces to mimic the tooth that you're taking out. And then deliver it and do all 3 roots at the same time. And for this, I do it dry because it's taking up the venous blood that's there. I can do this wet sometimes in other types of cases, but you go ahead and compress this, and as I compress it, you're going to see the venous blood filling this up. And then we just suture over the top. Let me take our bone plugger for this. And then we can do our histology. We do the histomorphometry. And you know that it's an OsteoGen grafted site because you can see a couple little particles of OsteoGen left as it continues to turn over. But look at the quality of the bone here. It's already organized at 3 months. This is amazing. We can use it as on-leg grafts by sneaking underneath the periosteum adjacent to something. Here's a case where we needed to place an implant in the area where the lateral is, but if I place the implant where the bone is, the implant's going to be all the way down here. The lateral incisor is going to be a huge, long tooth. So what I do in these cases is I place the implant to its proper position, take a tissue bunch on an OsteoGen bone matrix, layer the bone matrix over the implant carrier, and then close the flap. And that's going to be my lateral and vertical, my horizontal and vertical bone graft in this case. I'll skip ahead here while we reposition the tissue right there. So we got a really nice result with this. Sinus graft procedures. Here I'm going to show, this is a specialized crustal approach. This is called a trephine assisted sinus graft, where we're going to graft a sinus that's completely pneumatized. The sinus is literally 1 millimeter away from the crustal bone, but the crustal bone is nice and wide. I'm not going to go through the bone with this. I'm just going to score it. I'm not going to drill through. Then I'm going to take an osteotome. And I'm going to up fracture this the same as we would on a lateral wall, but in this case, we're going to do it crustally. So now it's not movable yet because I'm going to green stick fracture this. So what's going to happen is I'm going to have to take my mallet. It's going to take me a few sharp taps on this until that plate just goes ahead and enters right into the sinus. There it is. Now look at the bellowing of that sinus as that patient breathes in and out. Look at how thin that bone is. Now I'm going to take my OsteoGen block material, hydrated with autologous plasma, and I'm just going to go ahead and place this into the sinus and hydraulically lift the membrane. And if there was a little bit of a perforation, big deal. There's no particulate here. It can extravasate through a small perforation, even if there was one. That's why I choose to do this. So we can add, a couple of cc's worth of material in here, just through the crust. Then we just close this. Don't need any membranes over the top. Get good primary closure. Then go back in a couple of months and place our implants. Skip ahead here for a second. All right, now it's down. Now the sinus is filled up. And with nothing else, now just close it. Don't need any kind of membrane or material over it. Post-operatively, we've changed our antibiotic protocols on this. Before, for most of my career, the go-to antibiotic in this case was amoxicillin. Amoxicillin, 500 milligrams, used to be QID 4 times a day. It's now TID 3 times a day. But we've changed to azithromycin. Not only is it a macrolide antibiotic, it also has anti-inflammatory properties. So it's antibiotic, but it helps to push the macrophage population to polarize to the M2 side. Early inflammation is good the first 3 days. After 3 days, inflammation starts to break down tissue and break down graft material in the wrong way. So azithromycin, the Z-Pak, is the drug of choice, the antibiotic of choice post-operatively for our implant cases. So I'll show you one last case, and that last case shows the use of 3 things: collagen releasing graft, and autologous plasma. I call this my trifecta. And I say that because it contains the 3 most important things in regeneration. 1, a calcium releasing material, which is OsteoGen. Collagen containing, because it contains type 1 bovine Achilles tendon collagen. And 3, it contains growth factors through the use of autologous plasma. It's essentially sticky bone. So here's an endodontically treated tooth that was retreated, failed. It still has a draining fistula. We graft it. We graft out 2 roots. This is the immediate post-op. You can see it's relatively radiolucent. This is the 1-month post-op, maintaining good crustal height without resorption, without remodeling. But look what's happening. The lamina dura is starting to disappear in only 1 month. Normally, in a lot of these graft cases, years later, you can still see the lamina dura. That's how biologically active these things are. Now, this is the 3-month post-op. The lamina dura is completely gone. Look, no loss of crestal bone. But look at the homogeneous nature of that bone. Now I'm going to re-enter this. And what's amazing to me, this is again after just 2 to 3 months of healing, look at the size of this ridge. It's a 12 millimeter wide ridge. No loss of volume, height, or lateral. And when I opened it up, I said, well, you know what? I'll probably find a fair amount of particulate at crest. And you know what I found? Nothing. Good, hard bone. Look at the mineralization of that bone at crest. I don't get that when I use particulate allograft. And then the placement of implant. Watch when we drill the osteotomy. Look at the bleeding from the osteotomy. All right, and that's grafted bone. Look at that. Look at the bleeding from here. And then the delivery of this implant. I'm going to skip here, just going down to the end, then filling it up with a little bit of PRF. That's what the immediate post-op. And this is what it looks like after loading, where the bone continues to grow coronally, which is the opposite of what we find in normal cases. That's how biologically active this is. So that the clinical crown is the same as the clinical crown on the adjacent tube. So in conclusion, composite grafts facilitate the grafting process. They help to maintain ridge architecture. They resorb at the same rate as autogenous bone is produced. That's important because that's the fastest we can regrow bone. As fast as autogenous bone can be produced, that's how quickly this graft material is disappearing. It eliminates the need for membrane coverage because if you use PRF, it has a built-in PRF membrane. You don't need collagen membranes over the top of this. It achieves ideal bone mineralization and density in the least amount of time. I'm literally going back in 2.5 months to place my implants instead of 4.5 months. Now, because these plugs are exposed at the surface, do not use chlorhexidine or any alcohol-containing rinses until the epithelialization over the plug is complete or the incision lines are closed, or you will degrade and kill off all those cells. If you need to use a post-op mouth rinse, use Stella Life. It's a botanical. If using whole blood, do not allow early salivary contamination. If you're not going to use PRF and just want to use whole blood, if we extract a tooth, we have the patient bite down on gauze. We have the patient bite down on gauze for 20 to 30 minutes. Why? That's how long it takes a clot to form when it's a red blood clot. And that's why you can't just let a patient close immediately after you place one of these plugs. You have to treat it exactly like an extraction site. If you're using plasma, the plasma is already mature. It is cell and fluid occlusive. If you need to mix an antibiotic with your graft material, such as in the sinus, a few drops of aqueous metronidazole, 5 milligrams per ml, is your drug of choice. It comes from an IV bag. If using post-op antibiotics, azithromycin is drug of choice because it polarizes macrophages to become M2 macrophages. It's cost effective, it's easy to handle, and easy to place and suture in situ. And with that, well, looks like we had perfect timing on that, 1 hour. This is my email address if anyone would like to contact me.